So 72 hours out, the experience of pain is going to be markedly different than if you had no nerve block and you're waking up in the recovery room, right? And so because we get you through that acute inflammatory response every day away from the surgery, you're feeling better. Think about when you get a bruise on your leg, right? It hurts the most the first day. But then by day 3 or 4, it's maybe a little purple, but it doesn't hurt as much. It's the exact same concept.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now it's time to roll back and start the first case.
Today on the podcast, we are speaking with Dr. Theresa Bowling. She is the Director of Anesthesia at the Connecticut Orthopedic Institute in Bridgeport, Connecticut. And we're really going to dig deep into the role of regional anesthesia and how our patients benefit from it during surgery and even after surgery. And Theresa just has so much knowledge to share. I am so excited, Chris, that we get to talk to her today.
And I can't wait to hear more about what her facility is doing and kind of the big steps they're making to, advance regional anesthesia even further. This is going to be a great episode.
Yeah, there's so much to cover. Hold on to your scrub caps. We will be right back.
Hi, I'm Chris Blevins.
And I'm Melanie Perry.
From the studios of Healthcare HQ, you're listening to First Case.
Joining us now is Dr. Theresa Bowling, Director of Anesthesia at the Connecticut Orthopedic Institute in Bridgeport, Connecticut. Theresa, thank you so much for joining us today.
Hey, Melanie, thanks so much for having me. I'm really looking forward to this.
I'm so excited. But first, before we get started with our conversation, I have to share a little fun fact, but it relates to the episode, I promise. But Theresa and
I've been waiting for this, by the way.
It's a really good fun fact, okay? Nice little story. But Theresa and I met in December when we were both on a mission trip in Honduras. And Theresa, what really stood out to me about you, besides just how fun you were, I promise you're really cool to hang out with, but also to work with, because our patients had such impressive pain control and the effectiveness of the blocks that you gave them, because when we were there, we were actually able to see our patients, not just in surgery and leave and not see them again, but we saw them in follow-up. We saw them in PACU and in phase 2. So to really see how well their pain was controlled really impressed me. So when we were lining up guests for the season, I'm like, we have to talk to Theresa, got to talk to her. And so that is kind of the connection to how I know you, but also just why I'm so excited to have you on the show. So why don't you, I can stop talking now, and why don't you just go ahead and introduce yourself and tell everybody a little bit about who you are?
Sure. And I want to just, echo your sentiments. It was such a delight to meet you. And Honduras was really a special treat for me as well. It had been on my bucket list forever. We did something like 60 cases while we were there. And really made an impact on a professional level, so enriching, but on a personal level, made so many new friends, including yourself. So happy that we connected there, of course.
Well, thank you.
So a little bit about me, born and raised in Long Island. I've lived in Connecticut since I did my residency at Yale. I'm currently the Director of Anesthesia for an orthopedic hospital at St. Vincent's Medical Center in Bridgeport. I'm also the co-director of the Regional Anesthesia Fellowship. So my passion for regional anesthesia has been a long time coming, since 2008, and something I have the honor of doing every single day.
You're amazing. Yeah, and that you said the word regional anesthesia, which is really where I think we are going to be going with the most of this conversation. But today, the goal with the conversation is to take a deeper look at the role that anesthesia plays in combating the opioid epidemic. And there really is a lot that we can discuss, but we see so many nerve blocks and we hear all about ERAS protocols in our surgical departments. And so I thought that this was just a really good place to start talking about regional anesthesia. What is it? What are we including when we use this term? So how do you answer the question, what is regional anesthesia?
Well, bringing it down to the brass bones, essentially blocking or anesthetizing the area of the body that's having surgery, as opposed to general anesthesia where you're anesthetizing the entire body, the brain. And that's what most people, associate with a breathing tube, an endotracheal tube, the patient being unconscious in the operating room. Whereas with regional anesthesia, we can block a limb, the upper extremity, the lower extremity, and now abdominal wall, chest wall, and cause less of a physiologic trespass to the patient. So they have more rapid awakening and less side effects from general anesthesia.
That's amazing. Yeah. I think for just those listeners who maybe are not in the operating room, we've mentioned several times like the ERAS protocol. Would you mind describing that in layman's terms?
So ERAS stands for Enhanced Recovery After Surgery. And the goal of that is to improve the patient's outcome so they have a faster recovery, decreased length of stay, and less complications or side effects from opioids. So regional anesthesia, let's call it nerve blocks because that's really what it is, allows patients to need less medication, less anesthesia, and most importantly, less opioids. And they can recover comfortably because the nerve block does the heavy lifting for the pain relief afterwards.
What does the pain relief afterwards really look like when we're talking about nerve blocks? How much benefit are the patients getting, and what is the nerve block doing after surgery for the patient?
So, bringing the nerve block down to what is that really? Nerves go out through your entire body and they go along nerve impulses and neurons. And so the way regional anesthesia works is local anesthetic blocks that transmission of that impulse so that the pain receptors get activated wherever the surgery is, but that pain is never transmitted to the brain. So by the local anesthetic blocking those impulses from getting to the brain doesn't even know it's having surgery. So that allows the patient to recover comfortably. Think about when you have local anesthetic at the dentist, right? You have the local anesthetic injected by the dentist. You have the procedure, and then at some point that local anesthesia wears off, right? So what does that look like? Well, to answer your question, it depends on what kind of surgery you had. Are you having major orthopedic surgery with fusion, or are you having a minor hand surgery? Both of which can be treated with a nerve block, but what that pain is going to look like postoperatively is very different. The other issue is that pain is very subjective. There's an objective component and there's a subjective component. Everyone feels pain a little bit differently. The nice thing about nerve blocks, among all the things that it does, is that it prevents that pain from happening in the postoperative period. Now, how long is that? That depends on the type of local anesthetic you use.
So I know, just going on that layman's terms, when I spoke with friends of mine about what we were doing this season and the topic and, talking about regional anesthesia, some of them just looked at me so wide-eyed. And I think that there's this fear of, going into surgery and not feeling like you're just going to be knocked out and completely asleep. Like that's what, having that full body anesthesia effect. But those of us who have had babies, and thank you, Lord, for an epidural, that was, thank you, right? But, so for those of us, that was the way that I described it, to my loved ones when having this conversation. But do you feel like from a general public that there needed to be buy-in from your patients, maybe that didn't have the medical knowledge and in describing, hey, this is what we're going to do to you in the operating room? How do you start that conversation with your patients?
So if you had asked me that question in 2008, I would have said, I have to sell it to the patient and the surgeons. Fast forward to 2023, our patients come very well educated. You can't pick up a newspaper, a journal, read the news, or listen to the news without hearing about the opioid crisis. So patients now come in saying, what can I have that I don't need opioids in the postoperative period? They come in knowing about nerve blocks because they've read about it. So it's a very different landscape than it was over a decade ago. Having said that, when patients come in and don't know what it is, it's very easy to educate them and just bring it down to what we talked about. We're going to block a nerve so that you don't have pain when you wake up, or you'll have minimal pain, and that you'll need less opioids and may even be able to treat your pain with over-the-counter medication like Motrin or Tylenol, so on and so forth. The other very important part of this is patient education. Patients need to be realistic about what pain is afterwards. So you need to change the terminology to, our expectation is tolerable discomfort, not zero pain. Because anybody who picks up Netflix or reads the news has seen all the documentaries like an opioid crisis, right? There's something on Netflix now, right? A couple of different ones, right? So, again, without going to the details of that, the bottom line is they sold OxyContin for years as a drug you could take for a lifetime. And if you look back at the ads, they actually showed women, housewives back in the day, that said, essentially the ad was, you'll never have to have a headache again. You won't get addicted to opioids and oxy. Fast forward billions and billions of dollars later, we know that's not the case.
Wow. Yeah, that is, I did not know that OxyContin was billed as a headache drug and that they said that you would not get addicted to it. That blows my mind.
Like BC powder, right? Snort this.
Yeah, right. and so I think back, and like I had surgery back in 2020, and there wasn't really any discussion about any type of nerve block for me for what I had done or anything like that. And I came home with a prescription for like, I think 45 oxycodones. I mean, like so much medication. No, I did not take it all, and actually shouldn't, but still have the bottle sitting in a cabinet because I'm terrible about throwing things away, which is another story and discussion for another day.
That's another podcast,
but,
right?
Yeah, but my actual question and the point I'm getting to is that you said that years ago you would have had to have sold the patient on having a nerve block and this type of pain management for their surgery. And now patients come in educated and they are asking for these things. What changed in the dialogue and in the conversation? How did that education start coming about so that patients were aware that they could have a nerve block or that there were alternatives to their pain?
The internet.
Gotta love the internet.
Right. So in 2008, our 70-year-old patients probably weren't cruising the internet and using Google. And now with the, advent of technology and at the fingertips with the phone, you can Google anything you want. So I think that, whether you like Dr. Google or not, Dr. Google exists, right? The other thing that's a big difference, and I just had this last week, for example, I had a patient come in who was having a total shoulder replacement, right? So our block nurse tells me the patient's refusing a nerve block. And I'm like, what are you talking about? Who refuses a nerve block? So I go to talk to the patient, and the wife says, I've never heard of this. I had surgery 10 years ago. I don't want you doing a new procedure on my husband. So I said, well, there's nothing new about this, ma'am. The bottom line is it's been around for decades and decades, but now it's really the standard of care, especially at this hospital, which interestingly enough, when the surgeon came in, he echoed that. He goes, why wouldn't you have a nerve block? So after I also then explained to her that we do tens of thousands of blocks a year at our very own institution, and I have the data to support it. And so I think when you can speak from the heart and say, I've personally done 10,000 nerve blocks, and it is incredibly safe, and there's the reason why it's the standard of care here and at every institution, then she came around, and of course we did the block, and he did beautifully.
And I'm sure that the experience with the block afterwards and the experience after surgery was just all the more able to sell them, I guess, if you want to go back to the selling mentality, but sell them on the benefit of it. And then when it comes up in conversation later, then they're able to word of mouth pass that on to other people who may ask about their procedure.
That's exactly right. Word of mouth, right? Your friend telling you has a lot more weight sometimes than the doctor even telling you, right? So you're right, word of mouth. And as our patients are getting older and more of them are having hip replacements and total joints and major spine surgery, age isn't a limitation anymore for major surgery. We've had patients that are 100 years old, literally 100 years old, coming in for surgery.
Yeah.
Now, that's a patient you really want to do a nerve block on, right? Because as you get older, the blood-brain barrier gets very thin. These patients are prone to postoperative, mental status changes related to opioids. And that's a huge problem, not only upsetting to the patient, but their family, right? All of a sudden, you see mom or dad, and they came in, pretty bright and chipper, and now they're slurring their speech, and you can't arouse them. Terrifying for them. Plus the added cost of being in the hospital for an extra couple of days. We can't forget about the cost of medicine. And decreasing length of stay has a significant impact on the hospital's bottom line. Hospitals are struggling to make ends meet.
So you have this phenomenal facility that has, not just regionally, but nationally. And I wonder if you could walk us through what a patient that is going to get a block goes through in that facility. Those of us who are surgical technologists that, our home is the operating room. We've seen blocks done there, but we've also known that our patients could be blocked in pre-op prior to, what is that determination? What is the journey to getting a block look like for your patient preoperatively?
So I will tell you there's multiple ways to do this. I'm going to talk specifically about what works at our practice. In my career, I've been tasked with educating other doctors how to lead and develop regional anesthesia programs. So I think the way we do it is the best way. That's the way I teach other people how to do it. And I say that from the heart, not to say that my way is the best way, but having seen all the ways, that's what I think. So in a nutshell, the education starts before they come to the hospital. So let's use total joints for an example, right? When the patient sees their surgeon in our institution and my previous institution, they're already said you're going to have a nerve block. So they come in prepared. We have the benefit of having a nerve block nurse, a dedicated nurse who sees our patients before anesthesia sees them and talks to them about the nerve block. So this is, a multiple front attack here as far as they're hearing it from multiple different people. Then we hand them a written brochure because I'm sure you're all well whether you personally had surgery or not, it's very nerve-wracking, right? You get to the hospital, it's scary. All right. So then the nerve block talks to the patient. Then we come in, we do all of our blocks preoperatively for orthopedics. The benefit of that is I'm a big fan of preemptive analgesia, right? If you give the block before the surgery, you don't elicit the surgical stress response. Think about it. When you use an incision, make an incision with a knife, that's assaulting the patient, right? Yeah. You're assaulting the patient. So if your body doesn't even know that's happening, you can use so much less anesthesia. The patient could be awake, but nobody really does that, right? So we use propofol, the magic white drug, right? That keeps you asleep, but you wake up right away afterwards, non-opioid, non-narcotic, non-nausea. So that's what happens. And then the other important part is to educate the patient what's going to happen afterwards. Now, you've seen blocks in the operating room, correct? That's what you told me? Okay, right. So there are options to do it in the operating room, but operating room time is expensive, right? You do the block outside the operating room. Say you have a surgeon that does 5 total knees in a day, right? We can do a nerve block in under 3 minutes, but say it's 10 minutes. That's 50 minutes you're adding to the OR schedule if you're doing 5 procedures in a day. That means that surgeon could probably do another shoulder case if you were doing all those blocks outside the operating room. Now, some blocks you can do in the operating room, and we do preferably do them like our spine blocks. Patients under general anesthesia, we do the block after they're flipped onto their stomach, and that's great. It's a great patient satisfier because they're asleep when we do the blocks. But we give everybody a cocktail when we're blocking them anyway with Versed, so most patients don't even remember it. It's certainly tolerable. Not infrequently, the OR nurse will come out to get the patient, and the patient says, when am I going to get my nerve blocked? And she'll come up to me, she's like, Theresa, the patient didn't get blocked. I'm like, what are you talking about? There's a sign that says, I've been blocked.
It's that amnesionic effect of Versed, right? Yeah. Those of us who are control free. Every time I've had surgery and they've come to bring him like no Versed for me because I want to see it all when I get rolled in. Other patients
Not me. I'm like, give me the verse ed. Give me the verse ed.
Absolutely. Well, and there's another point to that, right? Because I think it is that like the nervousness that patients feel in coming into the operating room and wanting to just not remember it, right? And so there's that misconception that by having a nerve block that's going to control your pain, that there aren't other methods of pain relief and anesthesia that will be used. And so I'm sure you have to add that into your conversations with your patients that, you know, from an IV standpoint, we will also be controlling your mental state while you're in the operating room. It seems to be a very multifaceted education that you have to give your patients regardless of the procedure.
Yeah, and so you bring up a really good point. I mean, I can count on one hand how many patients have wanted to be wide awake during their surgery, right? And even if they do, we generally talk them out of it, right? Because the surgeon doesn't want that, right? Most surgeons don't want their patients talking to them in the middle of the operation, no matter how good they are. So that is the most common things patients will ask. Well, I don't want to be awake for my operation. I don't want to hear a saw. I don't want to hear a drill, right? When they're having orthopedics. So that's, you tell them, have you ever had a colonoscopy, right? When you have propofol for a colonoscopy, you go to sleep, you wake up, it's like nothing ever happened. So you reassure them that they're not going to hear, feel, or remember anything. In addition to the nerve block, as you know, for lower extremity, procedures, we do a spinal anesthetic. So on top of that, we can really reassure them you're not going to have any recollection of what's going on. And that's really reassuring to patients, right? Most patients don't want to know anything. And that's okay. That's really the way it should be, probably.
Yeah, sign me up. I don't really want to know anything either. Once you start working on me. Now, I have serious control issues too, so I want to be completely in control of my mouth and my faculties until you're ready to completely knock me out. But other than that, I don't know what's going on. But you said something that actually made me think, and it makes perfect sense, but I just hadn't thought about it before. But when you do a nerve block on a patient, that area then suddenly, it's numb. Duh, that's what it's for. But that means that when you go to cut the patient, when you go to begin the surgery, then that perception is blocked, correct? So even though they're asleep, they're not getting all of that sensory input for the cut. Is that correct?
You're completely correct. So again, that's so when you have an incision, it elicits what's called the surgical stress response. And that's exactly what it is. The surgery, meaning the incision, elicits a response from your body that all of these cortisol and epinephrine and all of these hormones that are really meant to protect the body, these neurotransmitters, get released in a flood. And that causes inflammation, and it causes a whole cascade of increasing blood pressure, at rapid heart rate, all the things that you'd want if you were historically out and got assaulted, but not in the operating room. And because that doesn't happen, we need so little anesthesia to keep you asleep. But, I want to go back to ERAS and enhanced recovery after surgery. That is multimodal, meaning that we're using multiple low doses of anesthetic, like you're cooking, right? A little bit of salt, a little bit of baking powder, a little bit of this and that makes the cake. So we'll use a low dose ketamine, a low dose lidocaine. We'll use IV Tylenol. We'll use non-steroidals like Toradol. By combining all of those things in small doses, you actually get the same analgesic effect as if you were using high dose opioids.
And then the patient does not have that stress response. They do not have all of those assaults on their system when they are in the surgery, which then only improves their ability to recover after the fact because they didn't experience all of that.
And the wound healing.
That's amazing.
Yeah. So, just to clarify, they're still being assaulted, right? They're still making the incision. But having said that, the body doesn't know what's happening. So, just to loop back on something you asked me earlier about, pain afterwards. So think about it. Every hour after the surgery, your body is already healing, right? The inflammation is decreasing. So one of the values of the nerve block is, for example, if we use a super long local anesthetic, that can last 48 to 72 hours. So 72 hours out, the experience of pain is going to be markedly different than if you had no nerve block and you're waking up in the recovery room, right? And so because we get you through that acute inflammatory response every day away from the surgery, you're feeling better. Think about when you get a bruise on your leg, right? It hurts the most the first day. But then by day 3 or 4, it's maybe a little purple, but it doesn't hurt as much. It's the exact same concept.
That's awesome.
Yeah. Yeah, I don't know. I just sit here shocked and kind of just blown away at what we can do in surgery and with regional anesthesia to protect our patients and to improve their pain experience. I know I think back to my husband who has shoulder surgery several years ago, and he had a wonderful block done prior to his shoulder surgery. And I mean, the block didn't wear off. I think it was 72 hours before all the block finally had worn off, and he just didn't hurt. And because he didn't hurt, he was able to rest. He was able to really do the things you need to do after surgery to get better. And then once the block wore off, sure, he had some discomfort. It wasn't, completely pain-free. It's shoulder surgery. I mean, come on. But he was not in excruciating pain. And so you see the value of pain blocks and what they do for patients. Obviously, now we've talked about what it does for them before and during the surgery. And then the after effect of what it does is also just so beneficial to them.
Well, yeah, exactly. I mean, so, when you're comfortable, you have an improved recovery. So to go to your husband, he slept at night. Right? If you have 8 hours of uninterrupted sleep at night and then you're not barfing from the opioids, right? I mean, nobody wants to be throwing up after surgery. I mean, that's awful. I can't remember the last time we treated a patient in our recovery with nausea and vomiting. I used to track it as a metric. I don't anymore because it was so infrequent. Really, there was no way to improve upon that. Now, of course, it helps that we're giving IV anti-nausea medication, but that generally isn't enough to combat nausea and vomiting from high-dose opioids. So that recovery is faster, and that's why we've seen decreased length of stay, improved patient outcomes. Another great example is physical therapy, right? That is one of the most predictable factors for good outcomes after total joint. And if you can start physical therapy the day of surgery within hours because you're comfortable, that allows patients to go home, right? So now we're seeing total joints that go home within 4 hours of surgery, right? Their spinal wears off. They can go home because they're comfortable, right? The other rate limiting step that keeps people in the hospital is pain management. So we've had remarkable results with patients having major breast surgery, right? Really painful procedure on young patients who have got a lot of anxiety because they've got breast cancer. There's a lot of emotion tied to that, and there's a lot of emotion tied to pain. And we can do these nerve blocks. We do like these things called deep flaps. It's a 14-hour breast surgery. You have mastectomies, and they basically take your entire abdominal wall off, and they reconstruct your breast with it. I mean, they're 14, 16-hour surgeries. With the protocol we have, we now do 3 sets of nerve blocks. We block the breast area, the abdominal area, and the groin area, the entire truncal area. We do them before they make an incision. And these patients, I'm not kidding you, get 100 micrograms of fentanyl. And you guys know, because you're OR people, that's nothing. It's 2 cc's of fentanyl. I'm talking about no dilaudid, no morphine, no Demerol, nothing. And they go to recovery room and they are wide awake and they have no pain. And to the point where surgeons bring in their patients from Yale to our institution now, because the nerve blocks are so sophisticated. Patients are so happy. They wake up and they're comfortable. Now, they may need a little dilaudid along the way, but that's okay. I'm talking about like 0.2 milligrams, not 2, 3, 4 milligrams. Well, so that's been a real game changer.
It sounds like it. And I mean, coming from my experience in the operating room, we used to only be able to do nerve blocks on extremities. And so the fact that you're able to go into, the chest wall and we're able to do abdominal procedures with blocks, to me is just fascinating. It gives you a real precision in where you are putting the medication and, really identifying those nerves. And I think as technology has increased, we're able to identify that. That really helps you all in actually performing the blocks in that specific area, which I think is just phenomenal. You mentioned also the fact that, you used to use nausea and vomiting as a metric, and your institution has become just so renowned and you all are doing so many wonderful things. And I wonder, what is the research saying about the decrease specifically with you all in your post-operative narcotic prescriptions now that you all are so proficient at doing a variety of nerve blocks? And what all are you finding in the long term?
So I measure, as part of my dashboard for metrics for quality at the hospital, morphine consumption in the recovery room and over the first 24 hours. So we actually don't write for opioids for our patients that have neuroblocks in the recovery room. So the benchmark for us is less than 10% of patients get opioids in recovery room after a total joint, and less than 30% for spinal fusions. And let me just remind you, historically, our spinal fusion patients used to have IV dilaudid, patient-controlled analgesia for 2 days.
Oh, yeah, I remember.
We instituted erector spinae blocks, which is basically blocking the nerves in the back that, transmit pain from the incision and from the bones. These patients got almost no dilaudid. That was a huge game changer. So I look at that, and then I look at morphine milliequivalents for the first 24 hours. We've studied this at our institution because we do have some research folks. And so you can see pretty much across the board 70 to 80% reduction of opioids in any patient having a nerve block, all comers, if you will, plus or minus. And so unlike you, Melanie, I'm shocked as recently as you said that you went home with, 45, whatever it was, Oxy or Percocet or whatever. The other thing, having, surgeons that are well versed in that, that's where 1 in 15 patients become opioid dependent. Right? They leave the hospital with a boatload of narcotics, and then people that are prone are going to start to take it even though they don't have pain. And that, is a lifetime of despair, right? So that's the education on the surgeon's part as well.
Yeah, absolutely. Completely education all around for how we as a medical team, as a group of professionals are treating our patients and paying attention to their pain, but also managing it in a way to help prevent an addiction or any type of misuse of narcotics. I know we're getting close to time and it's time to get wrapped up, but I think that you just hit on it. And I want to pull out some information from an article that you wrote in Anesthesia News back in March of 2019. And you mentioned some of those statistics. And you said that nationally, more than 70 million patients per year are prescribed opioids for post-surgical pain, with more than 10% of those prescribed opioids within 7 days of surgery who are continuing to use them a year later. And that it's escalating their risk for drug-related harm. And I think you so acutely draw out the risk that we have post-surgically when we are continuing to prescribe these opioids when there are so many other options for managing pain. If we can educate our providers and educate our patients about their options to just improve their outcomes and give them better care.
One of the things I love about regional anesthesia, of all the things I love about it, because I'm so passionate about it, I could talk about it for hours. It's unfortunate that this show is only an hour. I think your listeners would probably get sick of hearing my voice after a while.
I don't think so.
But nevertheless, anesthesia as a care, and you guys know this, was typically preoperative, intraoperatively, and PACU, which stands for post-anesthesia care unit, right? When those patients leave the PACU, our care is done. But now, for the first time ever, anesthesiologists can have a long-term effect on patients' outcomes, right? To me, that's one of the most gratifying things of regional anesthesia, because now I can, in small part, maybe prevent, even if it's one person from an opioid addiction. The carnage that's left in the wake of that, not just for the patient, which is horrific, but the family. And everyone with that patient, their friends, their family, it's devastating, and it's a life of despair, as we talked about. And God bless the people that are able to get out from underneath that, right, and get into recovery. But, nobody wants to be there if they don't have to.
Absolutely. They call it the devil for a reason, right? And it sneaks up.
That's right.
And what's so hard is that the families and the patients, they just trust because my doctor gave it to me. It was prescribed. And what they're realizing is that,
That's right.
sometimes 45 pills isn't exactly what you
might
need.
Be a bit much.
Yeah, you could have had a big party.
Yeah,
that's for sure. Unfortunately, in the entire country, the Northeast in particular, especially the metropolitan New York City area, right, we've pretty advanced regional anesthesia, but a lot of areas don't have that. The other issue is complacency, right? I'm sure you guys see this amongst your colleagues that it's often the fact that people don't want to change their practice the way they do things because they think it's fine just the way it is, because they've had good outcomes. And getting, other anesthesia providers to step outside their comfort zone and learn how to do regional anesthesia and perform these blocks as part of their standard protocols. That's where myself and my colleague, that we do a lot of training, that's where we try to make a difference as well.
Dr. Bowling, I really appreciate you being with us. And I feel like I've learned so much just about, especially education. And, medicine changes all the time. And that's kind of the exciting thing, because every day is different. And the fact that this particular realm of medicine is growing and changing and it equals better outcomes for our patients is just phenomenal. Gosh, it is only an hour, which is just crazy because we get these amazing conversations with these experts. And I just learned so much and have such a good time. But, we want to leave the final words with you. So is there anything that you would like our listeners to truly walk away from this episode knowing or learning?
The benefits of regional anesthesia far outweigh the risks. There's risk associated with everything, but with regional anesthesia, the benefits so far outweigh them that I would recommend any patient who's having surgery to ask their anesthesia providers and their surgeon, is this available at this institution? What is the outcomes for this type of procedure? And what nerve blocks are available to me? Because they are cognizant of the risk of opioids. They want to have less side effects, not even the big ones, the nausea, the vomiting, the sedation, the drowsiness, and that there is a better way to have anesthesia, and they should have access to that and not to be afraid of it. It's really safe, and it really is a huge advancement in pain management for our patients.
Wow. Thank you so much, Theresa, for joining us today.
Hey, thank you guys.
It's been a pleasure.
Chris and Melanie, thanks so much for having me. I hope you'll have me back. I'd love to talk more about regional anesthesia. So anytime, it would be my pleasure. And again, I'm honored you asked me to be on the show.
It is our pleasure. So happy to have you. Thank you so much.
Hey, thanks, guys.
That was Dr. Theresa Bowling, Director of Anesthesia at the Connecticut Orthopedic Institute in Bridgeport, Connecticut, and also a very dear friend of mine, having only met her in December and worked with her for a week. But just so much respect for Dr. Bowling and for her knowledge and how her patients are benefiting from the care that she gives them. And Chris, I actually was really, I guess maybe just surprised that I hadn't thought about this before. But how our nerve blocks, when our patients have them, suddenly they don't get that whole cascade effect when their skin is cut, and and how it affects them in surgery. And so just walk away with that nugget of information that says, yeah, our nerve blocks not only are keeping them comfortable after surgery, but they're actually playing a pivotal role during surgery for how they respond to anesthesia. And I think that was just mind-blowing to me, because I really just hadn't thought about it before.
No, I hadn't thought of the actual physiological effects and how, we all are taught inflammation equals pain, but the fact that it helps the anatomy actually heal better, and what I thought was really amazing is how well that tied into our last season of patient advocacy, because she talked so much about educating and that how educated the patients were. And so, I think it's important for patients I think we focus so much on the procedure and do I need this surgery and what's going to happen afterwards. But I think our patients need to take it a step further and say, how am I going to be anesthetized and what are those effects? And the fact that her patients are coming back better educated than they were even 5-10 years ago, to me is just phenomenal. But we still have far to go, don't we?
Oh, absolutely. So far to go. And a lot of minds to change and a lot of people to educate, but so much progress has been made. And like she said, if even one patient is kept from an opioid addiction because of the protocols we have in place and because of the ways we can use regional anesthesia, then we have been successful. So I really think there's a lot to take away from this episode. But that's going to do it for today's episode. So on behalf of Chris, myself, and the whole team here at First Case, thanks for listening to this week's podcast.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.